Okay, good evening everybody, and welcome to the Kellogg Urban Knowledge Exchange. My name is Ben Bolgar, I'm Senior Director at the Prince's Foundation, and we're delighted to both co-sponsor and collaborate on this series. I think this is now the fifth in the series, so we've covered affordable housing, public art, rapid urbanisation, and we've got another, every 2 months we tend to have a series, so do look online and come to the January event on urban planning. This evening's event is of particular interest to myself because for the last 20 to 25 years we've been planning some rather large settlements around the country, here and abroad, including Old Age Children's Hospital. And we always, based on sort of common sense and wanting to do integrated mixed-use walkable communities, believe that if you make good public space, you will encourage people to meet each other in the streets and walk about. But actually, we've always struggled with the evidence base and convincing people that this is the best way to go. And I think, as everyone will know, as the government's driving us towards a target of 300,000 homes a year, the way we actually shape our places obviously is going to impact upon the way we behave as citizens of those places. So I'm really interested in what's going to come out of this evening's discussion. Thank you very much for all the speakers who are coming. We've got a really good lineup of people, and chairing this evening is Professor Carl Hinnigan, who's Director of the Centre for Evidence-Based Medicine and the Programme for Evidence-Based Healthcare, I believe, that's right, here at Kellogg College, and I can't think of anyone better to be chairing this evening's debate. Thanks, Carl.
Thank you very much. Thanks, everybody, for coming. It's about healthy cities, and I think that's a sort of paradox living in Oxford, isn't it? Anybody who cycles here, I know you take your life in your own hands on a daily basis. I come in from Headington, down past the Slade, past Cheney School, and I have to think about the healthiness of why anybody would actually ever cycle. And I also think, thanks for coming on this miserable night. So it's a pleasure to welcome you. What we're going to do in the format is I'm just going to set the scene, and then we're going to take 3 talks back to back, and then hopefully we'll have a healthy debate about the future of our cities and the NHS. It's interesting, when I was reading that, it's been estimated by the NHS that obesity alone costs the services £5.1 billion a year. So there, obesity one, but I looked up the figures to look at the cost to the NHS of our lifestyle and some of the choices we have. So alcohol and smoking, those of you who had a drink, you contribute about 3.2 to 3.3 billion pounds worth of cost to the NHS that we could save if you all gave up. Smoking's the same, so that's number 3. But interestingly, number 4, taking away drugs and diseases. What do you think number 4 is? Inactivity is number 5. That's about £1 billion, and we're miserable at inactivity. About a third of you never get off your chair on a daily basis in the country. It's really interesting. So we've got a huge... But what do you think number 4 is?
Not intellectual stimulation, is it?
No, not intellectual stimulation. In a place like Oxford, that should cost the NHS 0, I feel. It's interesting, isn't it? It's actually poor housing. Costs to the NHS is about 2.5 billion. So them 5 items alone are about £17 billion worth of cost to the NHS. Very interesting. And then some of the statistics. 27% of the population is obese, 50% by 2050. We're in a bit of trouble. 40 cities and towns have air pollution above WHO recommendations. 17 areas are at the limit. Oxford is one of them, right at the limit of air pollution. And like I've said, you mentioned physical activity. I feel like I should get you all out of your chairs right now and do some shake about. So we're going to go into our... So that's what I want you to think about while we do these talks is, particularly we're going to hear some problems and some solutions. I think what we'd like to do is think about what's feasible in that 2050 zone, that I think some of these bigger problems of obesity, pollution is one, inactivity, and poor housing. So our first speaker, I'm delighted, is Danny McConnell, who's a strategy program manager with NHS England and leads on engagement and spread for the Healthy New Towns, which you mentioned at the beginning. So I'd like to welcome Danny to speak. Thank you very much, Danny.
Thank you, Carl, and thank you very much for the invitation tonight. I am from NHS England, so as such I thought I would add a little bit more to what Carl's just kind of brilliantly set the scene for us. I think the answer to tonight's exam question is designing healthy communities the right response to an overstretched NHS? In a word, yes. But, and I'll come on to the buts a bit later. So I thought I would give a bit of the NHS perspective and explore some of the links between place and health. And then what we're doing about it in terms of the Healthy New Towns programme. But first of all, what I always like to do is have a little bit of an historical context. And in a formal sense, the links between place and health from a kind of statutory sense go back to the 1848 Public Health Act. And Edwin Chadwick rightly realised that actually our health has more to do with the places and the conditions in which we live than anything else. 100 years later, 1948, we had the creation of the NHS. In the same year, actually, as we had the Town and Country Planning Act, which gives us our planning system that we have today. And the care model of the NHS as well has not really changed since 1948, the way that we have acute hospitals and we have general practice, not really significantly different to how it was in 1948. So just to highlight the challenges that we face today, we are getting healthier, but we are paradoxically using the NHS more. We are living longer, and avoidable deaths have fallen, but improvements to our life expectancy are actually slowing down. And I think there was some interesting news from the States today that life expectancy has actually started to go backwards there. I might have got that wrong. I heard it while I was in the bath this morning. Yes, so it's going. Thank you. It's going backwards. So if we're not careful, we could also be going in that direction. Obviously, a very different context in the US with the opioid epidemic and various other factors. We're ageing as a population, which is a success. It's something to be celebrated. But with an ageing population comes specific challenges around more dementia, more frailty, and really significantly, we also have the rise in the numbers of long-term conditions that we're living with as we age. So a specific statistic that really highlights this, a decade ago, 1 in 10 patients admitted to hospital had 5 or more health conditions. That number is now 1 in 3 people. So we are gathering these conditions as we age. And over the next 5 years, the rise in people living with multiple long-term conditions is expected to increase hospital activity by 14% and will cost $4 billion. So with this, combined with the rising costs of things like drugs and different demographic changes, this starts to really eat into the £20 billion that this government's promised the NHS. So what are the risk factors for developing some of these long-term conditions? So Global Burden of Disease says smoking is obviously, as you all should know, the number one modifiable risk factor for poor health outcomes. This is followed by poor diet, high blood pressure, and being overweight. So very worryingly, we have amongst the highest rates of childhood obesity in Europe. So essentially, to mitigate some of these risks, we all need to move more, as Carl said, maybe get you out of chairs, eat better, and live, I would argue, in compact and cohesive communities. So this brings me on to place. So the evidence is very clear about the links between place and health. I would encourage you all to have a look at Public Health England's evidence review of spatial planning for health. Things like food environments, the proliferation of hot food takeaways in areas of deprivation, exacerbate health inequalities and mean higher rates of childhood obesity. Adults tend to be more physically active. Indeed, in denser places, we tend to be more active. We tend to walk more. It's good for business. It's good for restaurants, cafes, public transport, parks. But it's good for our health as well. And green spaces being associated with improved mental health. Homes, specifically, 10% of excess deaths are due to fuel poverty in the winter. Poor housing and its cost to the NHS, as Carl mentioned, specifically poor quality housing in the private rented sector. So I'll give you also an example of our many of the there was a story in the news a few months ago about urban extension areas, so places on the edge of towns and cities where we are entirely dependent on cars. And one of our demonstrator sites in the Healthy New Towns programme, Cranbrook in Devon, which is right next to Exeter, did a piece of analysis where they identified areas that are utterly car dependent on the outskirts of Exeter, and I think there were 3. And they overlaid that with NHS data, so they put planning data and NHS data together, and realised that people were becoming frail much, much earlier in their lives in these car dependent neighbourhoods. So we absolutely need to make sure that we are not utterly dependent on the car. That is absolutely crucial. So a really good example of planning and the NHS coming together. I'll get back onto that in a minute. But the response really from us, from NHS England, we had the 5-year forward view, which is kind of our strategy. We're now coming to the end of that. We're about to be superseded by the long-term plan, which for my sins I also work on. The 5-year forward view called for a radical upgrade in prevention and a change to that care model that I mentioned, the way that we've traditionally delivered care, making sure that we're managing conditions more in the community, making sure that there's a greater role for primary care, and breaking down some of those traditional barriers. So the 5-year forward view recognised that new housing developments specifically are places where we can try and embed prevention from the beginning, and we can explore how we design and deliver services in a different way. So Healthy New Towns programme, 10 demonstrator sites, launched in March 2016. We recently produced our leaflet, which precedes, and I think there are some on that table if anyone wants to have a look at them. It's essentially got our 10 principles that we've come to through the evidence, through working with the Town and Country Planning Association, with colleagues in the King's Fund. Chris has been supporting us on the programme, the Young Foundation and Public Health England. So all of our demonstrator sites have been exploring how we embed health and wellbeing. Less so on the evidence, it's more about taking the evidence and putting it into practice, which is the bit that we really fall short on. And in 2 other things that the programme's been doing, engaging with industry. So we have a network of 12 housing associations and developers, right from your high volume builders like Redrow through to your small innovative ones like Happiness Architecture Buildings, which is Happiness Architecture Beauty. I forget what the B's for. It's a good job this isn't a podcast. So that's Kevin McLeod's outfit. So very innovative and focused on quality and design and doing something a bit different. So big mix of members. But looking at the role of industry and how we can sort of steer that super tanker of development and big developers to try and do the right thing when it comes to placemaking and making healthy places, not just nice places. We've also been engaging a lot on government policy. So talking to them about the National Planning Policy Framework. There's a Chapter 8 that's now better, hopefully I think as a result of us lobbying them. And they're also now producing the National Planning Policy Guidance, the bits of guidance that sit underneath the framework. And we're hoping to have a bit of input on that. In our experience through the programme, place is a focus, place allows the context. Place is where systems like the NHS and like local government come together. Historically, I think we've been really focused on delivering services rather than the places in which they're delivered. Through the Healthy New Towns programme, we've got various partners to come together, NHS, local government in terms of planning, public health, developers and voluntary sector and community groups, absolutely crucially. And they've come together to create a shared vision for what health and wellbeing should be in a particular area. The NHS has lots of data that the planning system can use, and the planning system can actively plan out specific health outcomes, or at least go some way to doing that. Wider things that the NHS is doing, so we are moving the way that we deliver care to a more population health management focus. We've got these new things called integrated care systems, and these look to integrate different services and more proactively manage population health rather than everything being about hospitals. new geographies are emerging from these integrated care systems. So we're now talking more about systems, the three geographies, systems, places, and then neighbourhoods underneath that. And also wanted to mention really an NHS response is the value, the social value of the NHS. The NHS is the largest employer in the country. 1.4 million people work for the NHS. We need to take care of the people who work for the NHS. We need to be a good employer. We need to make sure that we increase our links with the voluntary sector in communities. We also need to make sure that the way that we procure services has a social value to it as well. So looking at smaller businesses closer to specific NHS trusts, that kind of thing, and that's really important. But there are wider challenges to all of this, to creating healthier places. The acceleration in house building potentially has compromised quality, and we need industry to take responsibility for that. But we also need to in 2012, the Health and Social Care Act meant that prevention and public health services came out of the NHS and into local government, which is a great thing because that's where the wider determinants of health and the responsibility for them largely sit. But there have been particularly challenging cuts to local authority budgets and the public health grant, which really makes it pretty challenging for the NHS, really. If we're cutting services that support upstream health, and also in the context of a challenging economic situation, it's absolutely inevitable that downstream, so in A&Es, in general practice, in mental health services, we are experiencing higher volumes and larger demand, and we're struggling to meet that. We're about to go into winter in the NHS. There was something in the news today about us being in a permanent winter, but winter is a particularly trying time, and that's because that demand is turning up at the front door. So just to finish, really, we need greater action on healthy places. The evidence is really important, but the evidence base will never be perfect and complete. What we need to do is put it into action. We need to create these healthy places. We need to work together as a system and the NHS can't act alone in that. We really need a greater place-based focus. I think there's interesting things around the devolution agenda. There's also a potential role for some sensible policy making, but really ultimately health is for the health starts at home, and hospitals should just be for repairs. So thank you very much.
That was excellent. I actually do work for the NHS, and it's nice to think somebody's going to take care of me. I'm feeling a lot happy about NHS England, so thank you very much. Our second speaker is those involved in healthcare will be very well aware of the King's Fund, very influential reports all about healthcare, but in many areas of policy. So it's my pleasure to welcome Chris Naylor from the King's Fund.
Thanks very much, Carl, and it's a pleasure to be here this evening. Thank you all for braving the weather. I think Danny's opening remarks really set out very clearly why we need a different approach to health and well-being in this country. The NHS is a much-loved institution, and rightly so, but it's sometimes said that it's more of a sickness service than a health service. We've heard the statistics already this evening. We're living in the era of long-term conditions, and that means that we need a system that gives as much emphasis to prevention and on helping people to live well as it does on cure. And as part of that, we really need to be thinking about the role of place and the role of communities for all of the reasons that Danny has already described. I think one of the first messages I wanted to make in my presentation was that if we're going to do that, if we're going to be thinking about place and local communities and how they can contribute to health, then that can't be something that's led by national bodies. It can be enabled by national bodies, and the Healthy New Towns programme that Danny mentioned is a really excellent example of a national programme that's trying to catalyse change at the local level. But fundamentally, it can't be led nationally. It has to be enabled nationally and led locally. If you think of examples of when national politicians attempt to champion the need for renewal in local communities and re-energized civic life, it tends to go badly wrong. Think of the big society, think of David Cameron. So that takes us, if national governments and national agencies can't do this, that takes us into the question of what is the role of local government and cities in improving the health and well-being of the population. Now, one person who's written a lot about the role of cities is Benjamin Barber, who wrote a number of books on this, and I thought I'd read out a quote from one of his books where he tries to say why cities have emerged as a big concern in lots of countries recently. So Barber argued that the challenge of democracy in the modern world has been how to join participation, which is local, with power, which is central. The nation state once did that job, but recently it's become too large to allow meaningful participation, even as it remains too small to address centralised global power. The solution, though, stands before us. Let cities, the most networked and interconnected of all of our political associations, defined above all by collaboration and pragmatism, by creativity and multiculture, do what states cannot. So Barber puts this argument very forcefully that nation states are failing and that cities and local governments need to step into that vacuum. Whether or not we agree with his overall thesis, though, I think what we can agree on is that city leaders are playing an increasingly assertive role in national and international policy making when you look at debates around all sorts of issues like climate change, for example. So as a health organisation, we at the King's Fund wanted to do some research looking at what is the role of city leaders and city governments in relation to health. And we published a report earlier this year which addressed that question. It's called, very, very imaginatively titled, The Role of Cities in Improving Population Health. I really have to work harder on coming up with creative titles for reports. And I want to give you just 4 examples from that report of roles that city governments and their partners can take in relation to population health. The first is about coordination. So an example of that is Amsterdam. So Amsterdam has been more successful than most other cities in reducing childhood obesity rates in recent years. And if you look at the kind of things they're doing, they're working at various different levels. So they're working with schools, they're working with local businesses, they're working with parents and employers. But actually the funny thing is that if you look at the individual interventions, some of them are not that different from things that have been tried in other cities where they haven't had the same success. So what's the secret of the Amsterdam approach? I think it's something to do with the fact that they are taking a whole systems approach to this. That's about multiple components led by different organisations, but held together through strong programme management and a strong central vision and leadership at city level. So I think that role in sewing everything together, coordinating and leading is a really important one that cities can be doing. The second role for city governments is around innovation. I think most cities like to see themselves as being engines of innovation, but our observation would be that some cities have been more successful at really trying to proactively create an environment for social innovation where we can have innovative approaches in relation to some of the social challenges that our cities face. In New York and Mexico City, they've created innovation labs within the city governments that are designed to help introduce fresh thinking about things like poverty and health challenges in the city. So in Mexico City, they've had a program of work that's all about making sure that children across Mexico City from whatever backgrounds have access to safe outdoor spaces. So that role in kind of creating a sort of innovation environment, I think, is very important. The third one is about mobilizing people and engaging local residents in action on population health. In Paris, they've done some really interesting work on promoting cycling and walking. And one of the ways that they've done that is by using their participatory budgeting process. So that's a process where each year the residents of Paris get to vote on how a portion of the city's budget is spent. And what they often find is that proposals around making Paris a more pedestrian-friendly city and a more cyclist-friendly city, and trying to improve the air quality in the urban environment, come really high on that list of priorities that are identified by local people. So that's given the politicians in Paris a really strong mandate to take robust action on that issue. In Madrid, they've been using digital technologies to try and work with the local population. So they've set up an online portal called Decide Madrid, which is trying to get local people involved more in decision making in the city. So these are all different ways of kind of trying to mobilise the population and create a social movement for health. The last role that I wanted to talk about was the role of city governments and local governments in placemaking, using their planning powers, as Danny's already referred to create healthy places. And I think what we see in some cities like Copenhagen is that planning departments have reconceptualised their role in recent years to really see themselves as being the purpose of their work as being about creating livable, people-friendly cities that improve the well-being of communities. And that involves working in a different way, and it involves measuring different things. So most of what I've said so far has been about the role of big cities, and I wanted to stress, to be absolutely clear, that actually some of this agenda needs to be led at a much more local level, at the neighbourhood level, or by smaller towns and cities. Because ultimately we can't create healthy places without having a really nuanced, granular understanding of people's lives. And one place that I'd point you to that's been doing really, I think, quite exciting work about that is Wigan. We've been doing some research on with Wigan that we're going to be publishing next spring. And the story in Wigan is that since austerity kicked in, Wigan Council has completely transformed the way that it works with local people and communities. And the whole ethos of their transformation is about having different conversations with the public that start from a place of open-mindedness and curiosity rather than assumptions about what people need and want in order to live healthy, flourishing lives. And there's a danger of that sounding really glib, but when you see it in practice, it is really powerful. And the remarkable thing that I think Wigan have managed to do has been about training everyone across the council, and increasingly in other organisations working in Wigan as well, to work in that kind of way, to listen really hard to residents and to have a consistent strategic focus on understanding the assets of local communities and trying to strengthen those assets. And what they've found is that working in that kind of asset-based way, far from taking more time, it actually saves resources in the long run. One of the key messages I want to make is that we need to strengthen our social infrastructure at the same time as improving the built environment. I thought I'd finish by coming back to the NHS and the role that the NHS can play in this, and some of the things I'm going to say on this will echo some of Danny's remarks. Earlier I made that slightly kind of easy observation about the NHS being a sickness service, not a health service. That's something sometimes people sometimes say. Actually, I think it's unfair in the sense that actually there are lots of things the NHS does which are preventative. There are lots of preventative services, everything from vaccinations to smoking cessation. But I think the important thing is that the NHS is not just a service provider and shouldn't see itself as being simply a service provider. And this is where I'm going to echo Danny, but the NHS is the biggest employer in the country. It has huge purchasing power. It has an ability to influence local economies in many different ways, particularly in parts of the country where there isn't a thriving private sector. It's one of the biggest landowners in the country, and it's also a very respected and much loved brand. And all of those things are assets that the NHS can use to try and improve the health and well-being of the population. So I think what we need to see is NHS organisations acting as what's sometimes called anchor institutions, rooted in their local community, playing an active role in shaping those places. And if the NHS does really embrace that part of its role, then I think the end result is going to be healthier communities and also a more sustainable healthcare system. Thank you very much.
Thanks, Chris. I was on an exotic journey then when you was talking, from Amsterdam, Mexico, Paris, Madrid, Copenhagen.
Can I just say that unfortunately we had to do all of the research over the telephone. So, it's a big shame.
And then it was Wigan.
Don't underestimate.
Yeah, no, I don't. I won't. Super. So I'm going to move on to our last talk tonight, which is from Shaun White, who's Head of Research and Insight at the Design Council. Over to you, Shaun.
Okay. Hello, everyone. And as the previous speakers have said, thank you very much for having me today, and thank you for coming out in the wet weather. So I'm Shaun White, and I'm Head of Research and Insight at the Design Council. And what brings me to the stage today, and the role of the Design Council, is the fact that our role is try and aim to make sure that we make life better by design. And we think that design can play a role in helping people have healthier, safer, and better lives. And we think that because of, I guess, 4 key reasons. The fact that we think design has a role in making sure that we have better places, better products, better processes, and that generates better performance. And some of those P's are the reasons why I'm standing here today, which is that we think that there's a role in thinking about how we combine thinking about better places and better processes, leading to better performance, is part of thinking about healthy placemaking. And the role that design can play in helping have some of those conversations and innovation that we need to have, just like Chris outlined about thinking about what residents really need from their places and spaces, the role that we can play in helping to think about actually new ways of thinking about housing and development and making sure that actually areas really meet the needs of its residents. So we've heard a lot today about some of the barriers, about actually why we might not be able to actually kind of really embed thinking about healthy places as readily. And we've also heard about the fact there's actually a lot of evidence about actually why healthy placemaking might be a solution. I'm going to tell you a little bit about a report that we produced that came out early this year, also inventively called Healthy Placemaking, which tries to answer some of those barriers. So as an organisation, we do a lot of work across the UK, looking at doing design reviews, working with local areas to actually embed and make sure that healthy placemaking is featured in the way that areas are developed. And we encountered through our work the fact that there's a lot of evidence that shows it's a good thing, but the practice around it actually isn't always adopted. And where we kind of get to is the fact that the evidence is there, but that vision isn't necessarily turning into reality. And we wanted to investigate, well, why is that the situation? And we wanted to take our own understanding based on our own experiences, but we wanted to go a bit wider than that. And we worked with Social Change UK to do that. So we carried out a piece of research where we went out and we talked to about 600 built environment experts about, okay, how do you see for healthy placemaking? Do you know about it? What are the barriers to doing it within your areas? And what we generally found is that people had an awareness of it. They thought it was a good thing. And some of the things that you've heard earlier this afternoon were echoed, but it doesn't necessarily translate into delivery. There are a number of different barriers, but there were 5 things that stood out across the board from senior leaders through to delivery organisations about why that was the case. And they were, firstly, a lack of funding. There was insufficient funding in it, and about 4 in 5 of them identified that. It's the fact that the requirements or expectations of developers didn't match with that expectation to really focus on health. Thirdly, there were other priorities. Thinking about health and health outcomes were not seen as the primary focus around making new developments and new housing areas. Fourthly, Also, the requirements and expectations of politicians proved to be a barrier as well. And finally, there was insufficient time. And those combination of factors meant that across the board, it was maybe slightly harder to always put the kind of good evidence about the fact that there was this real connection between making sure that places were built around people's health needs and actually translating that into practical reality. And it's a range of barriers. One that would require a combination response to actually try and tackle. But at the heart of it is kind of the idea of having the more a greater need to have consistent policy, commissioning and practice to be able to tackle it. So what do we do? The reason why we wanted to better understand those barriers is to try and think about, well, what are the solutions? And when Carl was deciding the order of what we were going to go in earlier, I was billed as the solution person, so no challenge there. So I'm going to lay out, I guess, kind of 3 areas that I think actually maybe might help with trying to get over some of these barriers where we've got the vision to think about healthy placemaking, but it isn't just really translating into reality. So firstly, there's a role there for policy and commissioning. So given the fact that so much of the barriers associated with actually putting this to practice around the focus on around other priorities or it not really always being seen as a thing to do, there is a role here for national leadership and the way of policy driving and making sure that it's embedded into the way that decisions are made, that actually there needs to be this focus around health. And some of the things that the experts that we spoke to highlighted is that actually it's really difficult to push with clients, with developers, to think about health when there isn't actually a need to do so. So there's a potential role here for actually tightening up the legislation and thinking about specific measures that really make people think about this when they're planning and developing different areas. Equally, with the right type of support, there's a role for local authorities and the way that they plan. So again, embedding measures and requirements into the kind of practical construction of areas that they're leading on. Finally, there's an area around this kind of policy and commissioning angle to kind of, we are facing, and we often hear within the news, about crisis. So crisis in the NHS, crisis in housing. And I guess there's a moment here for leadership that is about thinking about, yes, short-term solutions to crisis, but not forgetting the long-term need to plan when we are thinking about the way that we develop our cities and our places so that we're really making those benefits for the future. So there's a role there for policy and thinking about how we commission. But it can't just come from there and we can't just wait from it. And we actually also need a bottom-up approach as well. So there's a real role here to think about with practitioners and for industry in trying to drive through and think about change through the work that they do in practically delivering places. So one of the things that is highlighted as a real area of success by the built environment experts that we spoke to is where there's collaboration, where we actually cut across silos, and the areas tend to be better developed and focus on those health outcomes where they are able to have conversations between each other. So a built environment expert talks to a public health official, they talk to a planning administrator, they talk to someone who works in infrastructure. And by breaking down those silos, they can deliver better areas. And that's something that can be practically done without waiting for policy. Secondly, it's how do other people get on board with this? So we've heard today the fact that actually there's a lot of evidence behind it, but who's going to champion that? And championing healthy placemaking needs to come from a range of different voices, from civil engineers to highways administrators. It needs to be a real thought process that everyone is on board behind. And finally, I talked about the idea of, across the board, we see these barriers faced between actually really prioritising healthy placemaking, regardless of whether or not you're a senior or a junior built environment expert. But what we do see is there tends to be greater buy-in, ironically, from that senior level around the importance of healthy placemaking, and maybe it's a bit less understood at a delivery level. There's a role there for training and learning and making sure that actually, for those that are really working on the delivery of different areas, they know about the latest principles, just as Danny highlighted about healthy placemaking, and are actually really thinking about inclusive design in the way that they are practicing their work. And that's something we're doing a little bit of work at the moment at the Design Council on, by thinking about a programme of training that can help those more kind of junior built environment experts really know exactly what to go to in the key principles. Finally, and as you would expect from a head of research and insight, there's a role here for evidence. So we've highlighted the fact that there's a lot of evidence in place already about the fact that thinking about the role of healthy placemaking and housing can help with these health challenges. So there isn't a need for evidence to get us started. But one thing that was highlighted by our built environment practitioners is the fact that they had very little to go on in actually demonstrating the impact where they had taken these things into account. They couldn't prove it. They couldn't say, actually, here's the demonstrable impact of what I've done. And there's a role here to play in thinking about actually more joined up processes around easy to work evaluation frameworks that help them translate good practice into something that they can show and look what that delivered. And one of the other things that came out of it was not just to show the outcomes of that work, but actually, as well as the what and the why, it's the how, so that we have translatable, scalable examples that other people can say, this is how I can do this in another area. So there's a role here for actually thinking about evidence that takes forward also away from just thinking this is something that's needed, to really showing that difference it can make. A final plea from that idea of evidence is from a former head of evaluation. And I'm going to borrow two phrases from the evaluation community, which is to measure what matters. So when we are thinking about these kind of common frameworks, is to focus on actually what is it we really need to understand. And secondly, to think about the precision for the decision. So when we're trying to think about demonstrating impact, it's to try and think about what gets enough evidence to say we should try this again. We can learn from this process, and it's enough to take action on the next steps. So to not let evidence be a barrier to innovation. To close, I've given you some barriers and hopefully some solutions, but a final observation. A lot of what we've heard tonight is a really common sense approach to thinking about the big challenges that are facing us and what are simple ways that we could actually try and overcome this. Sometimes the trouble with common sense, simple ideas is there's a lot of consensus about it, and we can all nod and say, absolutely, that makes total sense, but then we don't get round to do anything about it. And I think that's maybe the real barrier is we shouldn't wait for one type of action. There's a whole range of things that we could do to help try and really embed this and get it to work. Thank you.